So let's first talk briefly. This is not a patho course, but we want to talk about, why are anticonvulsants an important class of drugs? Well, seizures are a very common medical issue worldwide. It's a very complex topic. When we talk about seizures in emergency medicine, which is, where I come from, we care mostly about tonic-clonic seizures, the grand mal seizure, the one that everyone's familiar with, someone shaking, unresponsive. We don't care as much about partial seizures or absent seizures because those aren't going to be typically life-threatening. But certainly people who work in other fields, in pediatrics, in neurology, those are going to be important concepts. And certain drugs work really well on certain types of seizures and less well on others. And some can even exacerbate certain types of seizures. So, if you're working particularly in the field of neurology, be it pediatric or adult, those are kind of important things to know. What is a seizure? It's basically an abnormal discharge of cerebral neurons. So the neurons start firing in an uncontrolled pattern and cause, a depressed level of consciousness, and they also cause the muscles to twitch and shake. It's kind of like what I think of as VFib of the brain. So that's kind of what I think about it as. There are lots of different pharmacologic agents used in both the prevention of seizures and treatment. We're not going to cover all of them. Probably a new one's been invented today for all we know. But we are going to cover a few of the major drug classes, and we're going to look at some historic drugs, and we're going to look at some of the newer drugs as well. So again, the causes of epilepsy, which is seizure of unknown origin, is fairly diverse. There are multiple underlying pathologic processes. And so for this reason, no single drug is known to be efficacious at managing all these types of seizures and all the underlying pathologic processes that might cause these seizures. And as I mentioned, some drugs can actually exacerbate seizures, make them worse. And so the choice of our agent will be multifactorial, depends on seizure type, side effects, patient preference, and experience. All right, so the first drug we're going to talk about is phenytoin or Dilantin. This is one of the oldest non-sedating anticonvulsants. It was introduced in 1938, and it's actually still in use today. And when a drug's been around that long, it means that, it's an efficacious drug. It works well. You hope that the therapeutic index is wide, meaning, it can work at a variety of doses with a low toxicity, and that, patients can tolerate this drug, and that other drugs aren't necessarily superior to it. There are a lot of drug studies that you'll read that will say this drug was non-inferior to this other drug, except that it's much more expensive. And so what non-inferior means is they looked at, one drug versus the other, and usually they're trying, they've invented a new drug. They want to replace the old drug. Non-inferior means it didn't work any better. It wasn't necessarily any worse. It was about the same, but it's a new drug, and we've put an ad on TV, and we really want to sell a lot of it. And so, that's what non-inferior is. But, I digress. So back to phenytoin. It's been around for a long time, and it's because it works pretty well. There are lots of problems with phenytoin, and we'll get to some of those, but we'll get to that, but it's a drug that works pretty well. It's available in both oral and IV form. And it does have a new drug called fosphenytoin, which is a more water-soluble prodrug that actually is quite a bit safer to use, has fewer side effects, but remains still fairly expensive and isn't always on everyone's drug formulary. And it's a prodrug. So what that means is that it gets into the body, it gets metabolized to the parent drug phenytoin. And there are lots of drugs that do that. Pregabalin or Lyrica, which is a drug we use for restless legs, is actually a prodrug of gabapentin, and we can talk about that when we get to that drug. But that's what that is, and we'll talk more about that. This is just looking at the structural comparison. So phenytoin is here on your left, and again, I don't want you to get bogged down in the biochemistry, but this is an important and interesting biochemical molecule, and we'll talk about why. On the right is phosphenytoin, and they call it phospheny because they use phosphorus, but they chose to spell it differently. And that makes it more water soluble. And all you do is you knock off that phosphorus group, you metabolize that, and you have the parent drug phenytoin. And phosphenytoin has some advantages, and we'll get to that in a minute. But phenytoin is what's called a diphenyl substituted hydantoin. Again, I don't want you to memorize that. What I do want you to understand, though, is that this is what's called a heterocyclic organic compound, meaning that it's ring-shaped and contains atoms of at least two different elements. And you'll hear this term used for a lot of drugs. And so that means that there's certainly some pharmacologic importance for this structure. Our bodies like these ring-shaped structures, and they interact well with our receptors, they interact well with our enzymes, and so heterocyclic compounds are really ubiquitous in nature as ligands for, instituting some sort of activity. And that can be an endogenous ligand, meaning it's produced within your body, or it can be exogenous, meaning that we've manufactured it, we've delivered it to you, and we want some sort of action. So heterocyclic is that ring structure. What a phenyl group is just another organic compound that's a ring shaped and contains carbons and hydrogens. And that's where a lot of activity takes place. And so the importance of this is that heterocyclic rings are important structures in pharmacology. And a lot of these occur both naturally and as pharmaceuticals. And again, we're not here to learn the biochemistry, but I just think it's kind of interesting to, my cat just jumped up on my screen. Hold on, sorry. All right, screen's still up, so that's good. All right, so phosphenytoin's on the right and is a prodrug of phenytoin, right? So that means it's metabolized to the parent drug in the body. It's actually metabolized to phenytoin and formaldehyde. And so if you're familiar, formaldehyde is an organic compound that's used in the preservation of bodies. That's not something you necessarily want building up in your body, but it's metabolized very quickly using folate, and so it's not really of a real concern. Phenytoin, it's between 70 to 100% bioavailable in oral form. So bioavailability, remember that means when you ingest a drug by the oral route, there are certain things that are going to interact with that drug that are going to make it more or less bioavailable. And by bioavailable, that means how much of that drug after you ingest it is now in your bloodstream, right? So certain things can include pH of the stomach. So certain drugs are going to be less bioavailable because they become ionized, meaning they now have a charge. And that charge means that they are now polar and less likely to cross non-polar lipid bilayers, which are present in all of your cells. So that's an important concept, right? So pH, if you put a certain drug in a certain pH, depending on whether it's an acid or base, right, it's either going to stay non-ionized, which can cross into cells because cells are have non-polar lipid bilayers that are the membrane of the cell that allow for certain things to cross or not cross, or it may become ionized, meaning it's now has a charge, it's polar, and it won't be able to cross those cell membranes. So that's one thing that affects bioavailability. Another is first pass metabolism. We're going to get to that again momentarily, but that's when the drug, after getting introduced in the stomach, goes right to the liver. Some of it gets metabolized, some of it gets cycled back to the small intestine, And depending on how much the liver decided to take out, right, that's going to be how much of that drug is bioavailable to us. And anything that we give IV, right, that's certainly going to be 100% bioavailable. And we're going to review bioavailability kind of time and time again. So the onset of action of this drug is between 10 and 30 minutes when we give it, both orally or IV. And it has a duration of about 24 hours. So that's good, right? In that, if we give this drug, it's going to work in 20 to 30 minutes. That's good if you're trying to prophylax against a seizure. But if you have an acute seizure that's occurring, or you have status epilepticus, which means seizures that are just ongoing and continuous, right, then that is not going to be a great drug for that indication. But it does work in 10 to 30 minutes, and it lasts a long time. It lasts for 24 hours. So that's good dosing for patients. It means you don't have to dose it as frequently. The elimination half-life is about 10 to 22 hours. And so remember, half-life is the amount of time to eliminate half of that drug, and it takes 6 half-lives for that drug to be totally eliminated from the body. Doesn't mean it's going to be efficacious that entire time, but it's an important concept. This drug is highly protein bound and mostly to albumin, and it's metabolized in the liver by the cytochrome P450 enzymes. Remember, the cytochrome P450 enzymes reside in the liver, and what they do is break down chemicals, and they do it through really 2 phases, sometimes 3. But phase 1 is by making that chemical more reactive, and we make it more reactive so then we can then attach peptides that make it more water soluble and able to be eliminated, through the kidneys. All right, so again, this is a pretty old drug. This has been around for quite some time. And what does it do? Well, it works by blocking voltage-dependent membrane channels, and it blocks specifically voltage-dependent sodium channels. So remember from your prior lecture, we talked about ligand ion channels. That means something has to bind to a receptor to open that channel. And we have voltage-dependent receptors. And those are when you change the, when you change the polarity of the cell, or, how polarized it is, either positively or negative. So that's, the charge along the cell membrane. Is it really positive, which means it's going to depolarize, or is it really negative, which means it's not going to be depolarized? Depends on the movement of lots of different ions. And sodium is a cation, right? It's positively charged. And when that comes into a cell, it makes the cell more positive and more likely to depolarize. What phenytoin does is blocks the sodium channel. And so we decrease the likelihood of an action potential, and we decrease the likelihood of depolarization, which means that neuron is less likely to fire. And remember, when we talk about epilepsy or seizures, right, that means that you've got this firing of these neurons. If you block that sodium channel, you're going to block the availability, you're going to block that neuron from firing, and you're going to stop the seizure. So this is a good drug, and that's kind of the understood mechanism of how that works. As I mentioned, phenytoin, it's not really very water soluble. It has a high pH to be water soluble. And so the absorption can be associated with some problems, and we'll talk about that in a little bit. Phosphonatoin, the prodrug, kind of overcomes those. So in therapeutic doses, we reach plasma concentration in about 1.5 to 3 hours. Again, that's okay if you're trying to, manage seizures as prophylaxis. But if you're trying to stop a seizure acutely, that's not so great. It's metabolized, as I mentioned, by the cytochrome P450s, and it's excreted by the kidneys through what's called first order kinetics. All right. So that's another concept that we're going to explore here. So kinetics is, basically the rate of elimination of drugs. And you're going to hear these terms and you're going to think, well, is this important for me to know? Or is it just, something that I'm going to get in pharmacology and then forget? But the kinetics are actually important for thinking about drug elimination, especially in overdose, because things can change. But it's important to know, like, how are drugs eliminated and what's the mechanism by which they're eliminated. So with Dilantin, a small amount of the drug is unchanged. Most of it's metabolized, and then the kidneys eliminate it through first order kinetics. And so what that means is that the the rate at which this drug is eliminated from the body is related to the concentration of the drug in the body. So it's the constant fraction of the drug that's in the body eliminated per unit of time. And so the rate of elimination is really proportional to the amount of drug you have in the body. So the more drug, the higher the rate of elimination. And a majority of drugs are eliminated that way. Zero order kinetics is when a constant amount of drug is eliminated at a certain rate, and it's totally independent of how much drug is in the body. And a lot of drugs in overdose switch from first order to zero order kinetics. And so why I mention this is because a lot of people think about, oh, well, the half-life of this drug is X, the half-life of this drug is Z. And so we know that if this person has been on this medication therapeutically and has an adverse reaction, this is how long it's going to take to be out of the body. Or an overdose, we know the half-life is, 6 hours. So, in 36 hours, the drug's totally eliminated from the body. But that does change. So some drugs, switch from first order to zero order kinetics depending on how much of the drug is in the body. And so that's why I wanted to touch upon that and introduce that concept here. But this picture here is actually just showing, what the drug actually does, right? So it blocks sodium channels. When you block sodium channels, you decrease the likelihood that that cell can depolarize. And so you're going to, that's where the anticonvulsant properties come from. All right. This slide, you can review it on your own. It just shows you, what's the difference between first order and zero order kinetics. With first order, you increase the concentration of the drug, you're going to increase the rate of metabolism. Zero order doesn't matter. It's totally independent and just does it at its own rate. All right. So why, if phenytoin's so great, why don't we just use it? Why isn't it our only drug? Well, there's a lot of toxicity associated with phenytoin. Primarily, it's toxicity on the central nervous system, as well as the cardiovascular, and then what's called the purple glove syndrome as well. So the central nervous system or neurotoxic things that we see, they're pretty rare. We can actually measure levels of phenytoin in the blood, and that will give us an idea of what type of neurotoxic symptoms we might see. You don't have to memorize these numbers. These are easy to look up. But the first signs and symptoms we see at low dose concentrations are just nystagmus. That's when the eyes are kind of wiggly. When these get higher, you start to see ataxia. So they have trouble ambulating. We see slurred speech, tremor. At super toxic doses, you can have coma, and it can actually induce seizures. And the other thing is that phenytoin is actually considered an antiarrhythmic because it blocks voltage-gated sodium channels. So it has some dysrhythmic capabilities. And we're going to talk about that more when we talk about cardiovascular pathology or pharmacology. But what it does is it blocks the AV node. And so you're blocking the signal through the AV node, and it at high doses can be a dysrhythmic agent. We don't use it for that anymore, but you can see arrhythmias occur with this. And then this is the purple glove syndrome. This is from crystallization of phenytoin in the blood. and it causes extensive skin necrosis, which is not good at all. Here's the dosing. I'm not going to talk about dosing. This is just for your own review. You can review these independently, but I did put a couple other things here, which is, do we need to adjust for liver? Do we need to adjust for kidney? And then you'll also see something called the pregnancy category. So renal adjustment, we do that because lots of drugs are, excreted by the kidneys. And so if you have renal dysfunction, right, we know that certain drugs are not going to be excreted as well, and that might increase their toxicity. So we think about that. We think about hepatic adjustment because some people might have liver disease, and that means they might not be able to metabolize the drugs. And again, that can lead to an increase in the concentration of that drug in serum and cause some toxicity as well. And then I included something called the pregnancy category, and you see I put a letter D here. So what that is another concept that's really important whenever you're giving drugs to women who may be pregnant. And this is an area that a lot of people can get in trouble with if you're not paying attention to it. So most drugs will have a pregnancy category, and it's A, B, C, D, and then X. So A means that they've done some appropriate human studies on that drug and there's no risk. B, right, we haven't done a lot of studies, but we have some animal research and it's pretty safe in most animals, right? And so we consider it fairly safe. C means some of the, we have insufficient human studies. Animal studies show some problems, or there might be no animal studies and we don't have good data. You can keep reading down the line, and then we get to X, which means fetal risks are pretty evident. One thing though, when I took toxicology, forget which toxicology course at Northeast, it was one of our tox labs. We gave acetaminophen, Tylenol, to pregnant rats, and that caused a lot of teratogenicity, meaning that a lot of those rats had birth defects. So if we had tested Tylenol on rats, it would not be a drug that we have in human use today. But we know it's extensive. We have extensive human data that it's safe. So while take these for what they're worth, is what I'm getting to, is that human studies are really the most important. Animal studies can be helpful, but make sure that if you're giving a drug to consider the pregnancy category. All right, so that was a lot up front. We're going to try to whip through some other drugs here. I'll take a pause there, though, and see if anyone has any questions. And if you do, just blurt it out. Like I said, I've minimized my screen, so I won't even know who you are. You can ask whatever question you want. All right. Again, you guys are quiet. Concerns me. All right, so the next drug, carbamazepine. This is a very common drug as well. It's used to manage a lot of different things. We use it to treat seizures. We use it for a disorder called trigeminal neuralgia, which is kind of inappropriate firing of the facial nerves. And we also use it for bipolar disorder, for just management, but also for acute manic episodes of bipolar disorder. And there's some off-label use for its use in schizophrenia as well. You'll see this drug used quite a bit because of those indications. It actually does have something of interest that relates to genetics. So this medication, certain people that have the human leukocyte antigen 3101, and again, don't memorize that, but do remember the concept of human leukocyte antigen, right? Remember, that's the tag that says your tissue is your tissue, right? We all have different ones. HLA 3101 is present in Japanese, Korean, and certain European ancestry. And those patients are at high risk when they're on carbamazepine and other drugs that may affect that, of a reaction called Stevens-Johnson syndrome or toxic epidermic necrolysis. And those are drug eruptions or skin eruptions that can be really quite serious. We're not going to talk about them in detail here, but they basically cause, severe burns of the skin and can be fatal. And so carbamazepine is more prominent in patients who have the HLA 3101 allele, and those are kind of Japanese and Korean populations. So think about that. It's something to think about when you're prescribing these drugs. The other thing that carbamazepine has a black box warning for is that it can cause agranulocytosis, and that means it can depress all your cell lines that produce hemoglobin, hematocrit, white blood cells, platelets. And so you need to really be considerate of that. Carbamazepine also can be associated with suicidal ideation. So not a great drug for people with predisposition to depression. And it also has what's called mild anticholinergic activity, meaning it can induce delirium in elderly people. So make sure that you think about that. And then lastly, right, another side effect is that it can increase homocysteine, which is a compound known to increase cardiovascular risk. So it can actually worsen patients' heart failure and cause cardiac dysfunction. So there's a lot of good things about carbamazepine. There's a lot of things that aren't so good about carbamazepine. All right, so here's the dosing. That's again not something we're going to get too much into detail about, but it's something that I want you to know, not memorize, but know. And again, when you're giving drugs, this is easy to look up. You go to UpToDate, you go to a good drug handbook resource, and make sure that you're giving the right drug at the right time, and that you're thinking about those potential side effects. Carbamazepine, again, it's another drug very similar to phenytoin that's going to just basically block the sodium channel, and so that its mechanism of action. But I wanted to kind of introduce those other concepts as well, especially the HLA. All right, so this is a newer drug called Vimpat or lacosamide. And lacosamide, again, is a voltage-gated sodium channel blocker. And I see, Veronica, you have your hand raised. You had a question?
Yes, sorry, can you just re-explain what you said about the human lupus antigen with carbamazepine? What's important to know about that?
Yeah, so what's important to know is that, right, we all have different HLAs. That's what makes us unique. And so the human leukocyte antigen is that tag on your genes, on your tissues that say, this is my tissue, this is my, these are my cells. So some people have a type of HLA called 3101, so that, it's just a different way things are tagged. And then when that is present, we don't know the mechanism why, but it makes people more susceptible to serious side effects like Stevens-Johnson syndrome or TENS. And so what the mechanism most likely is that people with that allele, right, that pattern or code for HLA, metabolize this drug in a different way, or they handle its excretion differently from people who have a different type of HLA allele. And so that's the kind of important piece, is that we all have different HLAs. Certain HLAs are going to maybe change the way our bodies handle those drugs. And so it puts them at risk for different side effects. And so the reason I introduced that is because genetics can play a role in which medication we give to people. And we know that certain genetic traits can play a role in how drugs are metabolized, how they're distributed, their efficacy. And so that's kind of the overall overarching concept that I want you to understand. Nothing more in depth than that. Does that explain that?
Yes, thank you.
Great. All right, so Vimpat, lacosamide, it's also a drug that inactivates the voltage-gated sodium channel. All right, so that's its main effect. So you're seeing, basically these are just building on, the other drugs, right? So, and I just wanted to kind of take a quick look, right? Let's just, I said we're not memorizing structure, but you can look at that structure of phenytoin, right? You see those two heterocyclic rings and that phenyl group. All right, now we're looking at carbamazepine, right? There are those heterocyclic rings again, those nitrogenous groups. And now we're looking at Vimpat, and you can see, again, these heterocyclic rings, you have nitrogens. And so those are clearly kind of the structural components that are important for interacting with the voltage-gated sodium channel. When we move the rings around, we change their structure, we're going to change the function of that, drug. What the reason that we're, constantly trying to change these drugs is they're looking for a better drug that has all the features that you want. You want it to have efficacy, you want it to have high bioavailability, you want it to be safely eliminated, and have a low side effect panel. And so that's why there's constant research. There's structural similarity, but the differences are going to account for how we absorb the drug, how it's distributed, and how well it's going to work. Lacosamide or Vimpat can actually be just used as monotherapy for focal onset seizures in anyone aged 4 and up. So it's a pretty safe drug. It's usually very well tolerated. It may cause a little bit of nausea, which almost every drug does, maybe a little lightheadedness, but it's fairly safe. The only thing that it does do is that it, again, because it blocks sodium channels, it may increase your PR interval, and that's the interval between the atria firing and the ventricles firing, but that's usually not particularly problematic. What's good about this drug? So we saw very similar structure to our other drugs, phenytoin, carbamazepine, but it's 100% bioavailability, got 100% bioavailability. We give this drug, it gets absorbed, 100% of that drug is bioavailable. It doesn't undergo first pass metabolism. And we're going to discuss that again. So that's good. That means we give the drug, all of it's available for use in the body. It also doesn't bind plasma proteins very effectively. So we saw with Dilantin, 95% of that drug is bound by plasma proteins. That means that drug, when it's bound to plasma, is not available for pharmacologic efficacy. It has to slowly kind of leak into the system as more and more drug gets metabolized. Lacosamide is only 15% bound to proteins, and so therefore a lot of that drug is available. It acts quickly, peak concentrations 1 to 4 hours, and the half-life is about 12 to 16. All right, again, we're not going to talk about dosing, but I wanted to put this up again just to then think about, we talked about renal and hepatic clearance. So in this case, you do have to think about, does this person's, the kidney function and liver function, because you do have to adjust the dose. So if you were to give these doses, these, normal doses to someone whose creatinine clearance is less than 30, so they have a pretty significant amount of kidney injury, you have to decrease that dose. And if you don't, you're not going to, you're going to build up higher levels of that drug and you're going to become super therapeutic or even toxic. And similarly, because of the way this drug is metabolized by the liver, you have to think about, liver function. And we do that by looking at liver enzymes. We do that by looking at, history of cirrhosis. And so this is a drug that you would need to think about, the kidneys and think about the liver. All right, so let's get back to that concept then of first pass metabolism. And we know that, a lot of drugs undergo this. Vimpat, we mentioned, doesn't, and that's one of its features that's, positive. But this is when, drugs that are absorbed in the GI tract get circulated to the liver, mostly by, getting into the stomach and then immediately into the hepatic portal vein. And you can see, that hepatic portal vein is going to take, that drug, bring it right to the liver, and then you're going to get some metabolism of the drug before it gets put back into the systemic circulation. And so drugs that have a high first pass metabolism, right, they're going to have low bioavailability because the liver is going to metabolize a lot of it right off the bat. And drugs that have a low first pass metabolism, well, they're going to have a higher bioavailability. So I just want to kind of continue to plug these concepts that are important to understanding pharmacology, right? Bioavailability, first pass metabolism, kinetics. Those are kind of the important overarching concepts for you to know. All right. Now, gabapentin, right? So we're going to talk more about GABA when we talk about the benzodiazepines, phenobarbital. GABA is an inhibitory neurotransmitter. So it binds to GABA receptors in neurons, and it opens chloride channels. Chloride is an anion, it's negatively charged. It decreases the charge along the membrane and decreases the likelihood that that cell will depolarize. And gabapentin, we initially thought, well, not we, I wasn't involved in naming it, but the pharmacologist who initially developed it thought, oh, this works on the GABA receptor. And in fact, we aren't really sure. But you see this heterocyclic structure, you see the nitrogen compounds, very similar in structure. Gabapentin is an anticonvulsant medication, and it was first discovered back in 1970, and it was mainly they wanted to use it as a muscle relaxer, but it was discovered that it had really these strong anticonvulsant properties, and it was really good for managing seizures. But the mechanism by which it did that really wasn't what we thought it did. Gabapentin is also used for post-herpetic neuralgia. It gets used for restless leg syndrome. So it's another one of those drugs that gets used for a number of different things. We see gabapentin used for anxiety and depression. We see it used in bipolar disorder. Again, we see it used in neuropathic pain, right? So it gets used for a number of different things. And then it also gets used illicitly because it has some activity on the opioid receptor. So when you're studying pharmacology, these are the drugs that you like because no one really knows how they work. So you don't have to memorize the mechanism of action per se. We thought, that the GABA receptor might be important, but that doesn't seem to be the case. What we do know is that gabapentin freely passes the blood-brain barrier and acts on neurotransmitters of a variety of sorts. Maybe GABA, maybe serotonin, we're not quite sure. It actually has a very similar structure to GABA, but it doesn't bind GABA receptors, nor does it influence the manufacture of GABA, the uptake or metabolism of GABA. So despite its name, it really doesn't seem to work through that mechanism at all. What we think it might do is work on calcium channels, which inhibit the excretion of neurotransmitters that are excitatory. And so those are serotonin, dopamine, histamine. Those are the kind of things that we think that gabapentin might work on. It does readily cross into the blood-brain barrier, and we talked about that when we talked about concepts of pharmacology, because it's highly lipophilic. And so it's, likes fat, it can cross through that blood-brain barrier. So it's highly concentrated in the brain. And that's really good when we want a drug to have action within the central nervous system, right? We want a drug to be able to get into the brain and achieve what it needs to do. It's not bound to proteins. So we know that's, good. It's going to have good action at its site of action, and its bioavailability is about 90%. So all good things. Again, here's some uses. Here's the dosing. It does need to be, you do need to decrease the dose for kidneys. You don't have to worry about the liver. It's pretty safe in pregnancy, which is not particularly true of many of the other drugs. And so this is a very, very common drug. And you can see it's used for alcohol withdrawal, fibromyalgia, neuropathic pain, post-herpetic neuralgia, seizures, and a variety of other things, which just goes to show you how little we know about its actual mechanism of action. All right, so we've hit a lot of stuff there. Why don't we take a 10-minute break, come back at 3 o'clock, so I guess 8-minute break. Let's come back at 3:00. We'll take a full 10. We'll come back at 3:02. Just try to absorb those concepts, right? We're not trying to memorize these drugs per se. You can look up doses, you can look up renal and hepatic clearance. We're trying to really see those overarching concepts. So let's meet back at 3:02, and then we'll again open with any questions, and then we'll continue on our discussions around some of the other important anticonvulsants. So I'll see you back in about 10 minutes at 3:02.
I can't see the PowerPoint. I don't think you're sharing your screen.
Ah, I meant, okay. Let me get
I
back to
didn't
that.
know on purpose
Yeah,
or what.
gonna go back to sharing. There we go. Can you see it
Yeah,
now?
I put it in the chat. I didn't want to interrupt you. Sorry.
Okay. There's not much to see there except for the structure.
Okay.
But yeah, so let me just. All right, let's do a quick review of everything we've talked about. All right. All right, so that's that structure. So that's probably why you're like, what is he talking about? There you can see that heterocyclic ring is gone. And so that means, it's going to have a different function. The structure is different, the function is going to be different. And so with valproic acid, the important things to know are, yes, it works on the sodium channel. It also enhances GABA. It also blocks calcium channels. And so as a result, it's kind of multifactorial, and it has kind of a broad spectrum of uses, from partial seizures, focal seizures, to generalized tonic-clonic seizures. We talked about the cytochrome P450 piece. The other thing that this drug does is it interrupts what's called the urea cycle and can increase ammonia levels. And this has to do with the way that liver handles proteins. And we're not exactly sure the total underlying mechanism of this, but it can cause an encephalopathy or a change in mental status by increasing levels of ammonia. And that's something we see in patients that have severe liver disease, and their ammonia levels increase and they get what's called hepatic encephalopathy, and valproic acid can do something similar. All right. So again, this drug not only used for seizures, it's used for migraines, right? It's used for bipolar disorder. So you see this drug a lot. And you see it for people with migraines, with bipolar disorder, with seizures. It can be given acutely. It has a really quick onset of action. So it is a drug we give maybe in the setting of status epilepticus. And again, these indications are less important to know. We're just looking at kind of overall drug class, understanding their mechanisms of action and why they have these mechanisms. And then again, because of its activity on the cytochrome P450 system and the way it can interact with what's called the urea cycle, we generally don't use it in people who have liver dysfunction. And this is one of the most difficult drugs to spell. It's spelled incorrectly most of the time: levetiracetam, or Keppra. A great drug because we don't really know how it works. But again, look at this structural difference, right? We have no structural similarity to those other anticonvulsants we saw. We saw a heterocyclic, or six carbon ring structures. We saw the, nitrogen groups. This does have those nitrogen groups, but now we see this pentameric ring, right? Five carbons. Again, we're not doing the biochemistry. What I just want you to see is how structurally different these drugs can be. And when they're structurally different, that means they're going to be acting differently on, receptors. So the precise mechanism of how, and I'm just going to say Keppra works, is not entirely clear. No one exactly knows how it works. Those are the best drugs to be studying, right? Because I'm not going to ask you how this drug works, because no one really knows. It is different from the other anticonvulsants that we talked about, and that it's not metabolized by the cytochrome P450 system. So it's completely independent of that. It's metabolized independent of the cytochrome P450s and basically uses some enzymes to do that. And so that can be really good, right? You don't have the concerns of interaction with all the other like we've seen with all the other drugs. So it's a great drug. It's used for a lot of different things. We don't particularly understand how it works. It works for a variety of different seizures. It can be given both orally and IV, and we don't have to worry about it interacting with a lot of other drugs because it's not, interacting with that cytochrome P450 system. And it's incredibly well tolerated with very few side effects. And as we discussed with some of those other anticonvulsants that put you at risk for Stevens-Johnson syndrome and those NTENs, there's really very limited risk for that. So this is a drug that you see used quite a bit because it's effective. It has a good safety profile. It can be given both orally and IV. It's a drug that a lot of us turn to for the management of seizures because of its safety profile. So we use this a lot in the emergency department when we're managing first-time seizures or second-time seizures, because you can give it, you don't have to titrate it up, right? You give it as a single dose, and it's usually efficacious. We don't have to worry about a lot of drug-to-drug interactions. We can give it IV if you're in status. We can give it orally as well, and it's a pretty safe drug. So, we have a lot of experience using Keppra because of its safety profile. That's really, what to talk about there. So that's kind of the general overview of many of the anticonvulsants, right? There are tons of other drugs that are out there, more and more being developed. We can't look at them all. What we're looking at is just some general overall class actions of these drugs. So keep that in mind. What we'll shift to now is looking at some other drugs that work on the central nervous system and drugs that you will commonly see. And one drug that you'll commonly see, because many, many patients are on these, are what are called the selective serotonin inhibitors. And so these drugs are important antidepressant drugs, and they replaced another drug class called the tricyclic antidepressants, because these drugs are much, much safer than those drugs. And we'll talk about TCAs, but SSRIs are great drugs. They are antidepressants. We now use them for other things, and we'll talk about that fairly briefly. They're fairly safe, fairly few drug-to-drug interactions. There are a few things to think about, and we'll talk about them there. But the therapeutic action of SSRIs are basically that there's this theory of depression that people who are depressed have a deficit of serotonin in their central nervous system. And what these drugs do is just increase the level of serotonin in the brain, and therefore can help reverse that deficit and that depression. And what they do is they inhibit the reuptake of serotonin. So they decrease the way our neurons reabsorb serotonin and allow it just to sit in the synapse, longer periods of time and therefore continually activate those neurons. And by doing so, we feel that they have an antidepressant effect. So you should review, basically some of the, physiology behind this, right? We have neurons that release serotonin. Those bind to serotonin receptors on an adjacent neuron across a synapse. Then we release chemicals that break up that serotonin, and your neurons reabsorb it and remanufacture for reuse. What happens with SSRIs is they block the reuptake of that serotonin, let it sit in its receptor for a longer period of time, and by doing so, cause those downstream effects that we think are associated with depression. And so here's a variety of the drugs that are available, and then the things that we use them for. All right, so these drugs are used for major depressive disorder, generalized anxiety disorder, bulimia, bipolar disorder, obsessive compulsive disorder, panic disorder, premenstrual dysphoria, PTSD, social anxiety. So they likely have a lot, they're used for a lot of different things. And on the other side are the different drugs that we use: fluoxetine, sertraline, paroxetine, citalopram, escitalopram, right? All of these drugs, for the most part, have different reactions, and so or different interactions with the receptor, different kind of rates of efficacy and side effects. And so that's really how we decide which drug we're going to use. There's some drugs that prolong certain cycles within the cardiac cycle, so we might avoid those if someone has a predisposition to QT prolongation. There are some drugs that increase appetite, some that decrease appetite, right? This is really kind of the realm of people that are working with these psychotropics, but we kind of want to look at these drugs as an overall class action. And so let me go back to this. What the SSRIs do is that they primarily inhibit what's called the serotonin transporter, and that exists at the presynaptic axon. So that's the neuron that's releasing serotonin is going to release serotonin into the synapse, and it's going to bind to the receptor sites on the adjacent neuron. And so when you look at this picture, 5-HT in that circle on the top, that is serotonin. So that neuron releases serotonin into the synapse, and then it binds to those green structures on the other neuron, what are called serotonin receptors. They're going to cause a lot of downstream activation of a lot of different chemicals. They're going to open calcium channels. We're not going to get into the depths or the weeds in that regard. What we want to know is one neuron releases serotonin, the other binds to that serotonin or binds that serotonin, causes some downstream signaling of that cell, and then that serotonin gets metabolized or reabsorbed using what are called SERTs. And those SERTs are those blue circles, right? The serotonin gets taken back up, it gets metabolized, broken down, and then you make more serotonin by using those structures. So that's the general course of action of of the SSRIs. These drugs don't work. Most SSRIs only work on serotonin. They don't work on dopamine or norepinephrine, which are also thought to play a role in depression. Their primary role of action is on 5-HT, specifically by inhibiting those those serotonin transporters. Does everyone kind of understand that? All right. Problem is it takes a few weeks for these drugs to work. All right. So it takes 2 to 4 weeks sometimes for these drugs to work. Right. So if you're severely depressed and you start taking this medication, usually most of them are once a day, 2 to 4 weeks can really seem like a long time before you start to feel better. They also have a lot of side effects because we have serotonin receptors in other places. We have them in the heart, the myocardium, and when you block, these reuptake of serotonin there, you cause a lot of tachycardia and palpitations. We also have serotonin receptors in the GI tract. When you block those, people get diarrhea. So a lot of people will have side effects, and then some have an effect on the cardiac function to increase the duration of the QTC. We're going to talk about that more in a little bit, but just kind of want to get a general overview. But these are very popular drugs, right? They have a pretty good, safety profile. They're used, for a variety of different indications, as we see, and they're fairly safe to use. The only problems that we do see with regard to toxicity are that some drugs prolong the QT, which can lead to fatal arrhythmias like torsades. Citalopram is kind of one of the drugs that is most often associated with that. And then, the others less so. So, that's an important thing to think about. The other thing is that people oftentimes get put on multiple SSRIs or other drugs that may interact with serotonin. And you can see something called serotonin syndrome. And that's when these people get a change in mental status. They get fevers, tachycardia, diarrhea, nystagmus, myoclonus. So that's something to look after. And also, what isn't really talked about very much, but this is I did my master's thesis on, was that serotonin SSRIs can actually cause coagulopathy. So serotonin is an important part of platelet activation. And when you activate platelets, that's going to induce clotting. And we know that SSRIs actually block platelet serotonin and can cause a coagulopathy or increased bleeding. And so those studies were, early on, they looked at, is this a risk factor? It seems to be minimal, but it is something to consider when you are putting someone on an SSRI who's already on an anticoagulant like warfarin or one of the direct acting, thrombin inhibitors that we'll talk about later, or has a risk for GI bleeding or other kinds of things. So just something to think about, about those kind of drugs. Otherwise, like I said, it takes a while for the effects to occur. Some, upwards of 4 to 6 weeks for these drugs to have their action. Again, here's a list of the different ones, right? They all are going to have different profiles that are going to, indicate which are better for use for, certain patient populations. It's oftentimes just trial and error to see which drug's going to be working best. Sometimes you'll escalate the dose. Sometimes you'll just switch drugs. It's really a lot of trial and error. But unless you're working specifically in psychiatry, you're not going to be really prescribing these drugs acutely very often. And it's really a whole new other course on what, which drug to use and when, because you can see that the indications are pretty numerous. All right, so tricyclic antidepressants, right? These are an older class of antidepressant, and these were largely replaced by the SSRIs, but we're now seeing them used again for people who are either resistant to the SSRI, so continue to have major depression despite use of SSRIs, or we're also using them for neuropathic pain. And so you're seeing a lot of reuse of these drugs for people who have neuropathies. Now, these drugs are really good for depression. All right, so these are valuable agents in the treatment of major depressive disorder, but they have a lot of adverse effects, and they can be very toxic. So an SSRI, for the most part, you can overdose on SSRIs, and most of the time, nothing happens, right? And that's good. When you have major depressive disorder, we want a drug that we're prescribing to you that if you take an overdose because you're so depressed, you're suicidal, you're not going to see much effect. Rarely you might see serotonin syndrome. Rarely some drugs like citalopram may induce QT prolongation, but they're fairly safe in that regard. Tricyclic antidepressants, on the other hand, have a very narrow therapeutic index. And we've talked about therapeutic index, and we'll talk about it again here momentarily. But with tricyclics, the therapeutic dose is 1 milligram per kilogram. The lethal dose is 10 milligrams per kilogram. So that means if you take 10 tablets, right, that can be lethal. Whereas if you took Prozac, fluoxetine, if you took 60 tablets, you might have some tremor, some diarrhea, maybe serotonin syndrome, not very likely, but you're not going to have the toxic effects we see with TCAs. So that's good, right? That means that those SSRIs are safe. Tricyclics, very effective for treating depression, but it have a narrow therapeutic index. So let me talk briefly about therapeutic index, right? What that means is, and we'll talk about that when we talk about a variety of other drugs, is that's the kind of the distance between the dose that's effective therapeutically and the dose that is toxic, right? We want drugs that have a wide therapeutic index because that means you can give a low dose and you can titrate up to very high doses and not have any toxicity. Whereas drugs that have a narrow therapeutic index, right? That means you have a really narrow, degree of how much drug you can give. And the tricyclics fall into that category. We'll talk about digoxin, which falls into that category. We'll talk about lithium that falls into that category. So that's what the concept of therapeutic index is. All right. So the TCAs, right, you can see these are the different drugs and the different mechanisms by which they work. They work similarly to the SSRIs in that they do work on serotonin and they decrease the reuptake of serotonin, but they also block the reuptake of norepinephrine, which is another neurotransmitter believed to be involved in depression. They also block sodium channels, and we'll talk about why that's important because that can have some cardiac toxicity. The SSRIs are a class of drugs that are non-sedating. However, the TCAs, you can see, have varying degrees of sedation, varying degrees of hypotension, and varying degrees of toxicity that can both be the induction of seizures or cardiac toxicity. And so we'll talk about those drugs. Do I want you to memorize this table here? No, you don't need to memorize this table. What I want you to remember is kind of overall mechanism of action. And we also wanted to introduce the concept of therapeutic index. So the TCAs actually work on 5 different neurotransmitter pathways. They block the reuptake of serotonin and norepinephrine, again, in that presynaptic terminal, right? So that leads to just increasing the concentration of those neurotransmitters in the synapse, and therefore you get that constant kind of signal that those drugs are present. The increase of those, neurotransmitters is believed to be the primary antidepressant effects. The other effects that these drugs have are that they work on histamine, right? We talked about histamine last week and the role that histamine plays in anaphylaxis, but histamine is also a sedative. And so when you block histamine receptor, when you increase, histamine activity by blocking its reuptake, that's where you're getting the sedation. Doesn't have anything to do with depression, but blocking the histamine reuptake, that's going to give you the sedation that you see. It blocks sodium channels. as well. And that's where we see activity in the brain and in the cardiac system. And we'll talk about toxicity here in a minute. These drugs, for the most part, similar to the serotonin reuptake inhibitors, take a while to work, right? So that's concerning. If you're really depressed and you're put on a TCA and it takes like 4 weeks to work, 6 weeks to work, and you're super depressed, you're going to have downstream, you're at risk for suicidal ideations. Let me go back. I thought I put an EKG up here. So let me talk about the cardiac toxicity, because that's the thing we think about the most. So in the setting of tricyclic antidepressant overdose, what happens is that the TCAs block sodium channels. We're going to talk about dysrhythmics next week, 2 weeks from now, but blocking sodium channels basically prolongs depolarization. So it means that it takes longer for the ventricle to kind of repolarize. And when you take longer for that ventricle to repolarize, it makes it susceptible to some sort of arrhythmia. And the arrhythmias that we worry about are ventricular fibrillation, ventricular tachycardia, or torsades. Those are fatal arrhythmias. So even in therapeutic dosing, you can sometimes see prolongation of the QRS. For those of you who are familiar with that, right? That's the depolarization of the ventricle. And if you take longer to depolarize, you're at risk for these arrhythmias. We see prolongation of the QT interval, and that's repolarization of the interval. So interrupting both of those cycles makes the heart susceptible to possible arrhythmia. And in overdose, right, these drugs block those sodium channels, and therefore they prolong depolarization, prolong repolarization, and make the heart very susceptible to arrhythmia, right? The way that we reverse that is to give sodium bicarbonate. And what that does is it changes the pH in the blood. And when you change the pH in the blood, you actually change the shape of the receptor. And when you change the shape of the receptor, it kicks off the tricyclic antidepressant. And so it's no longer interfering with that cycle. We're not getting into toxicology per se here, but just something to kind of keep in mind as to why these drugs kind of were largely replaced by other the SSRIs, which have a much better safety profile. All right, so lithium carbonate, right? This was one of the first mood stabilizers, and it's still first line treatment for mood disorder, particularly bipolar disorder. It's very commonly prescribed for bipolar disorder that's characterized by manic episodes, and maintenance therapy for bipolar disorder. It's a great drug, but it too has a very narrow therapeutic index and has some downstream problems that we'll talk about. So we don't know how lithium works. It's been around for a long time. We have no clue how it works on the brain necessarily. It's rapidly absorbed. It has a very small volume of distribution, so it stays in the blood for the most part, and body doesn't even metabolize it. It gets excreted totally unchanged. So it's a weird compound, right? We give it, we don't necessarily know how it works. It stays in the blood for the most part, so it's not really well absorbed into target tissues, and it's not metabolized. It gets excreted completely unchanged from the body. We think it might have some role in modifying sodium transport. It might have some role in altering the metabolism of catecholamines. It might have some role in signaling second messenger systems that are involved in the production of catecholamines or the reuptake of catecholamines, but we don't have a real strong understanding of how this works. It's given orally. There's no IV administration. It does work a little faster than the TCAs or the SSRIs. It typically starts to work in about 1 to 3 weeks for lithium to show its effects. And it works for a long time. The half-life is upwards of 18 to 30 hours. So a pretty good drug, right? It's a good drug that we can use for major depressive disorder. We can use it for bipolar disorder, but there are a few problems with this drug as well. So one is that certain medications can increase serum lithium levels, and that includes NSAIDs, so like ibuprofen or other COX-2 inhibitors, angiotensin converting enzymes, diuretics, metronidazole, which is an antibiotic, carbamazepine, phenytoin, right? Those all increase the levels of lithium. So there's a lot of drug to drug interaction. So that's one problem. Another problem is that it has a very narrow therapeutic index. Again, the dose that's therapeutic compared to the dose that it's toxic is very narrow. And lithium can cause a lot of side effects. It can cause heart block. It can cause confusion, hyperreflexia, clonus. We can see renal injury. It can cause something called diabetes insipidus, which we'll get downstream to when we talk about endocrine system. It can affect the thyroid and cause hypothyroidism. It induces some weight gain. So there are lots of different side effects that mean that despite its efficacy, a lot of patients don't particularly want to use it because of all those, side effects. And so that's, something to consider whenever we're, administering these drugs. But it's pretty, it's a pretty good drug. The good thing is that we can measure levels of lithium in the blood. And so we can look at therapeutic levels and know, when someone's therapeutic or when they're toxic. And its volume of distribution is very low. So that means it's sitting in the blood. And if we need to take it out of the blood, we can. We can use a number of different methods to get it out, including hemodialysis. So if people do get toxic, we can do that. All right. Then lastly, we're going to talk about the antipsychotic drugs, the oldest of which is haloperidol, and the more recent is olanzapine. We're going to talk mostly here about olanzapine because that's kind of replaced, some of these older drugs. And olanzapine is what we call a second generation antipsychotic medication. So we use these drugs for bipolar disorder. We use them for schizophrenia. We use them for acute psychosis. And there's, a few other things that they can be used for, but those are really the major things that they're used for. And you can also, use olanzapine with the SSRIs for major depressive or SSRI resistant major depressive disorder. So it's a drug you'll see a lot of, for use for a variety of different things. It's available in a couple different, so olanzapine, which is what we're going to talk about mostly, is available in a couple of different forms. It can be given as an orally disintegrating tablet. Can be given orally. We can give it IV. We can give it intramuscularly. And so there are some advantages to that. If you have someone who has an acute psychotic crisis, right, you can slip it under their tongue and it gets absorbed very readily. You can give it IM, IV, and it can be absorbed very, very readily. The way that it works is primarily on dopamine and serotonin receptors. So it works on dopamine receptors by blocking dopamine in that postsynaptic receptor. All right, so it's going to block dopamine, which is an excitatory neurotransmitter. All right, we saw some of those other drugs actually enhance, dopamine sitting in that synapse. Olanzapine, Haldol, Seroquel, right? Their activity is to block dopamine from getting into that receptor. It also is going to block serotonin. And so those are the primary actions. So before, where we wanted to enhance those neurotransmitters, now we're blocking them. And again, the primary action is to block dopamine receptors. And by blocking dopamine, right, we're going to decrease the excitatory neurotransmitter of dopamine on that. And the effect of that is that you see a decrease in what we call the positive symptoms of schizophrenia. So we see a decrease in hallucinations, delusions, disorganized speech, thought, and behavior. And that is a positive effect, right, of those drugs. As I mentioned, we administer this drug by multiple different routes, and it acts pretty quickly through all of those different routes. From a pharmacokinetic standpoint, it lasts for a long time. Another thing that we like to see in these types of drugs has a half-life of about 50 hours with an average of between 30 to 50 hours. So you reach steady state concentrations pretty quickly. So it starts to work within about a week, and that's a positive, right? We saw the other drugs, it can take a long time for that to work. These drugs work pretty quickly. It does have a very large volume of distribution, right? Drugs, remember, we're talking about drugs that have a volume of distribution below 1 are mainly in the blood, the serum. Volume of distribution of olanzapine is about 1,000 liters. So it's widely distributed to tissues, which from a standpoint of, do we want this drug to act quickly? That's a positive because it gets absorbed at its site of activity very quickly. But it also means that removal of that drug could be a little bit difficult to do. This is a chart showing some different routes, different half-lives, all right, and some advantages, disadvantages. One of the reasons that olanzapine is favored over Haldol, which is a much older antipsychotic drug that's still used extensively, is that you don't have that risk for torsades or ventricular arrhythmias. It's not going to affect the QT as much as Haldol will. And it has a long half-life, so that can be good as well. Some disadvantages, all right, it has a low dose ceiling, so you can only give a max of 30 milligrams a day. Higher than that, you start to see some of the side effects that we don't want to see, like acute agitation, delirium, getting worse, those kind of things. But it's a great, safe kind of antipsychotic. The other antipsychotic that you'll see used fairly frequently is Seroquel. This is kind of one of the few that we see indicated for use in elderly patients. It can only be given orally. It's really rapidly absorbed, has a short half-life, and it can have some side effects, but again, it's fairly safe from a cardiovascular standpoint. We use it a lot in elderly patients with delirium. We use it for insomnia. We use it in the ICU for patients who are on a ventilator, who are delirious, because it is a good sedative agent as well. All right. Oh, this is the slide that was supposed to be under tricyclic antidepressants. This is what we're talking about when we talk about QT prolongation. We're going to get to that in more detail when we talk about cardiovascular drugs. So that is CNS part 1. All right. Again, we discussed our kind of major concepts like an hour and a half. All right, thank you for your attention, and we'll see you in a few weeks.
Thank you.
Thank you.